Good morning. This is Dr. John Bennett, broadcasting from dark Miami. It's 5 o'clock in the morning here. It's a little later in Pakistan and Nepal and India. We have another conference in the online ACNS online conference. Today we have the pleasure of having Salman Shariff. He's a neurosurgeon, noted neurosurgeon from Pakistan. He's going to be talking in this session about cervical trauma. And before I turn it over to Salman, let me introduce the panel. We'll start with Ipe. Ipe, good day. Ipe, you're muted. Unmute. It's a common mistake.
Yeah, I'm sorry. I don't have anything much to say. So thank you, John. Thank you very much for helping us organize this fantastic conference. It's a completely new concept, and I'm sure we'll catch on.
Very good. Welcome, Ipe. Go grab. Could you say hello? Yeah, unmute, please. It's everybody makes that mistake.
Oh, sorry. Yeah, everybody. I'm Gaurav Bhatta, a medical student from Nepal. Hello, everyone.
Very welcome, Gaurav. And VD?
Thank you, sir.
Yes, I am honored to be with you, and it's an amazing meeting. And I think in future we should continue.
Yeah. Very good, VD. And VD is going to give a talk at 7 o'clock. And Victor, greetings.
Really happy to see you. Nice to meet you.
Okay.
Yeah, Victor gave a great impromptu conference about an hour ago. Okay, Salman, welcome. Could you please introduce yourself and what your background, where you're working at now, before you start your introduction, please?
Thank you, John. I am a neurosurgeon. I'm actually head of neurosurgery at the largest private neurosurgical setup in Pakistan. We have a huge setup, and lots of our cases are mixture of spine and tumors. A lot of minimally invasive surgery, both for brain and for spine. I actually trained in UK, and then did a fellowship in US in spine, and have been back in Pakistan for 15 years now. And basically,
we fell off the PowerPoint there, Salman. I'm sorry to interrupt. Sorry.
Shall I put the PowerPoint back on?
Yeah, please. Well, okay, whatever you want, whenever you're ready.
Okay. And basically, I'm involved in a lot of educational activities. I'm actually the President Secretary for World Spinal Cord Society. Also, I am the President-elect for Middle Eastern Spine Society, and I'm a humble member working for ACNS and WFNS and helping them with various things. And we have loads of friends here and friends all over the world. In support of all of them, we've been able to contribute and help and teach people all around the globe. And I have some of them sitting here who are doing a great job for us and teaching us, and lots of people will benefit from this, I'm sure. So we must do this.
Thank you.
Thanks, John. Thanks. Okay. Let me put up my slides.
Okay. This is a new tech. We're all learning it. Okay. Yes, we see it. Very good.
Okay. Can we see my slides?
Yes, we can.
Okay, great. This is actually Karakoram mountain range in north of Pakistan, which also extends into India, Nepal, and it's an amazing area. And you can see, as I'm sure lots of you know, that out of the top 20 peaks in the world, 6 are in Pakistan. And this is one of my friends up on the mountain range last year. So let's start with cervical spine trauma. The reason I chose this topic is because there is a big problem all over the world, especially in our part of the world. People are not sure what exactly are the guidelines, and these guidelines have to be followed very aggressively and to the point, because you can save lives if you do that. So I thought it's very important that, especially for young people, cervical spine trauma guidelines should be out there. So what are the factors that lead to delayed diagnosis? We know this all the time, that you've got other head injury, other injuries, patients who've got altered state of consciousness, when you've got poor radiology. You know, the radiographer at 3 o'clock in the morning is not sure what they're doing. There's no radiologist available to report it at that time, and you don't know what's happening if there's a junior resident on call in radiology. And patients with multiple injuries, obviously the trauma people are focused elsewhere and are not sure if a spinal injury is involved at the same time. Patients who are at risk, who are they that we're going to miss? All patients who have sustained polytrauma, we should think about that they have a cervical spine injury. Unconscious trauma patients, and patients with minor trauma, and then they complain of neck pain or arm numbness, and that's the time that we must think about that there may be a problem with cervical spine. And can we make a difference? Yes, we can make an impact. About 1/4 of these cases of permanent neurological impairment after cervical trauma have been attributed to injudicious manipulation by paramedical personnel. And that starts from at the site, then ambulance people coming into hospital, and then porters moving patients from one to the other table, examining physicians, radiology technicians, and all of us play a huge role in this, and all of us can make this impact and really make a difference for outcome. So when a patient comes in, intubation of trauma victim is done with orotracheal intubation, and it has to be rapid sequence if you want to give anesthesia. Obviously, decision who to intubate, we're going to come later. Collar should be removed and manual inline protection reinstituted. The routine use of a gum elastic bougie is recommended in these patients. So whom to intubate? We know that patients develop respiratory failure if their PaCO2 is more than 50 millimeter of mercury, or pH less than 7.3, or respiratory rate more than 20. When you have all these, then we call this respiratory failure. And intubation may complicate opportunity for close reduction of patients with these spinal injuries. So it is much safer if you reduce a fracture in the cervical spine if they're awake and they're able to communicate. Obviously, if you can't do that, there are other issues, then you do need to intubate the patient is in respiratory failure. So we assume that all patients who have injury C4 or above, who are either ASIA-C or below, will fail to maintain a respiratory effort in acute phase. So these are three important factors that we should remember. So it's C4 and above, ASIA-C and below, and obviously will fail if there's respiratory effort in acute phase. So these are the patients that we can think about intubating. So cervical spine can be cleared clinically if there's somebody who's fully alert, oriented, there's no head injury, there is no drug or alcohol. This is way back from 1994. Or the principles of evaluation of cervical spine obviously starts from assessing and classifying if there is any skeletal injury, if there's any neurological deficits, can we assess any associated spinal injuries, can we identify associated non-spinal injuries, and can we establish treatment priorities at the same time, at the time of assessment. And all these are very important. You can't miss any one of them. So general evaluation of the patient, obviously you're going to observe if there are any abrasions, laceration, deformities. For example, if there's an abrasion on the forehead, you think about some kind of a flexion injury, whereas palpation for localization of pain is important, because if it's tenderness in the midline, then you do think about that the problem lies somewhere in that cervical spine. Obviously, if you've got tenderness along the muscle or ligamentous pathway, then you don't worry that much. Neurological examination is important. Obviously, cranial nerves, motor sensory functions, reflexes, rectal tone, and bulbocavernous reflex is paramount, and as the patient has got control of bladder or bowel. Then the treatment obviously focuses on the ABCs of resuscitation. You have to have ABC before you think about anything else. The most important thing to remember for a spinal cord injury indicator is mechanism, and you need to know what the mechanism is. And there are obvious reasons. Could this be a flexion injury? Could this be a hyperextension injury? Some kind of compression injuries if you're coming from the top. You have got some kind of hangman fracture kind of injuries. Then there are hyperextension injury coming from the motor vehicle accidents, and then falls. All of these will have different type of fractures depending on the mechanism that's involved. So if you look at the mechanism per se, for flexion injury, obviously you think about your anterior subluxation, unilateral facet dislocation, very, very common. Bilateral facet dislocation, we see it all the time. Wedge compression fractures, flexion teardrop fractures, and Clay-Shoulders fracture as well. Whereas for extension, you think about hangman's fractures. That if you've got a hangman fracture, think about all the injuries that are involved there. Compression, obviously Jefferson and burst type fractures, and complex is odontoid and mixed type fractures. Do we need a grading system for spinal cord injury? Obviously we do. And why is that? Because then we can classify a grade and say, okay, this patient's outcome may be this much, and in this patient we're going to go in acutely and operate or reduce or not reduce, or we can delay this patient or even not operate on a patient depending on the grades that are involved. Previously we used to have Frankel grading system. It is outdated. And the new system is exactly the same with little bit of a nomenclature difference to clarify that there is no ambiguity in the grading of the systems. So this is called the American Spinal Injury Association grading system. And it is used all over the world, and it's now the worldwide standard. We look at motor and sensory assessments, ASIA impairment scale, and clinical syndromes depending on incomplete injury or not. So this is basically the chart that you need to fill, and the chart has some important elements, motor and sensory both. So you can maybe pick out any one and say, okay, C6 injury, wrist extension, and say, okay, fine. But you just tick that and you know that C6 injury. So you think about C6 particular injury and you need to focus there. Sensory as well, if you do the same, then you can quantify where exactly is the problem coming from. And the level obviously come from where exactly the motor and sensory are. And these motor areas, the motor muscles, are very important for us to know that where exactly the level is lying. So ASIA impairment scale, complete, incomplete, and normal. So with complete, it's ASIA A with no motor sensory function, and the sacral segments are not preserved. So nothing is preserved. It's a complete spinal cord injury. Obviously, the outcome of it and compared to an incomplete injury is completely different. And it's very, very important that we differentiate between the two. Incomplete can be B, C, and D. For B, you have got some sensory function preserved below the neurological level, and it includes the sacral segment S4 and 5. That's very important for us to know. That's perianal sensation. With incomplete, the motor function is preserved below the neurological level, and more than half of the key muscles, which we had shown in the previous slide, below the neurological level, have a muscle grade at least of 3. So it's 3 or less than 3. It's less than 3. Whereas for D, motor function has to be preserved below the neurological level, and at least half of the key muscles below the level have to have a muscle grade of 3 or more. So the difference between C and D is basically motor level 3 or less. And the difference between complete and incomplete is sacral sensation preserved or not. And our outcome depends on it. So it's very, very important that we differentiate between the two. Whereas normal is ASIA E, whereas everything is normal. So why rectal examination? Why tone is important? The presence of rectal tone in itself does not indicate an incomplete injury. Sensation is important. A voluntary contraction of the sphincter or the presence of rectal sensation supports the presence of communication between the lower spinal cord and supraspinal centers. So telling us there is a favorable prognosis. So the bulbocavernous reflex comes into play. When you're a medical student, you laugh over it, but in spinal surgery, this is very, very important. Tugging on a Foley's catheter or squeezing the glans or clip, or you checking this electrophysiologically, you can get to see if the response is positive or negative. Positive means the presence of this reflex implies the lack of supraspinal input to the sacral outflow and is suggestive of complete spinal cord injury. So important is if this reflex is present, then you're saying that there is no flow coming from the top and you've got complete injury. If it's negative, then obviously in spinal shock, it's negative. You think that patient is in spinal shock and there is a chance that they may recover. So their motor recovery will differentiate in both of these patients. So it's very important to check this reflex. So recovery below zone of injury. If you look at complete or incomplete, it's important that ASIA A, 11% of them improve. 3% of them will improve to ASIA D or E, saying that to reasonable recovery, that they're able to do things on their own. And this is very important for us to know, because majority of the time I go and give lectures to places where people don't have access to these guidelines, And they think that if you've got complete injury, that's end of story. You're doomed. You're not going to end up anywhere. Whereas we know that if these patients are treated early, reduced early, and then they're hypertensed, then 1 in 10 patient will end up having some kind of reasonable recovery. And we know 1 in 20 patients will walk with some kind of an aid. So it's very, very important that we know that there's improvement can be made if these patients are treated early. Whereas the differentiation between Asia A and B is again humongous. If you see 11% versus 44% improved in Asia B. So that slightly sensation intact at perianal area could make that difference. We know that the signals are going through. And we know that of these patients, 28%, 1 in 4, will end up in Asia D and E, completely or near complete normal. And only 1 in 20 will get worse. So it's very important that these patients have to be treated aggressively and early. 55% of patients with Asia C will improve to D or E, and very few will worsen, whereas D, majority of them will improve to D or E, and only 2% will worsen. We all have to remember this chart, and we have to treat these patients aggressively because these are young kids who can be improved in majority of the time. And they have the effort with them that they can improve. If you look at the neurological examination, it has to be done every 1 to 2 hours until definite stabilization is achieved, and for at least 24 hours post-operatively, unless the attending physician says so. And after 24 hours, the frequency will depend on the attending physician, and evaluation should be based upon the Asia scoring system, unless or otherwise determined by the attending physician. And these are the guidelines now. And we know the first reliable Asia score that we can see is at 72 hours. This is a gentleman who had an injury, and I'm sure John knows, and was doomed, and he recovered. And well, people said it's a miracle. It wasn't a miracle. He had sensation, and actually his Asia A was properly assessed at 72 hours, realizing that he walked again. And all these patients can be helped, and that is very, very important for us to know. So if you look at recovery, and these studies are from 1990s, that if you had pinprick sensation sparing predicts motor recovery, so 89% versus 11%. So 1 in 10 of these patients they were able to ambulate in 1990s. So I'm sure we have got better ways of hypertensing and making sure that their spinal perfusion pressure is appropriate to improve these patients. Reflexes proximity of spinothalamic and corticospinal tract is very important. We know that corticospinal tract and spinothalamic tract lie in close proximity. If your spinothalamic tract is intact, all you need is a couple of millimeters more to go up to corticospinal tract and have some kind of recovery there. So it is very, very important for us to understand this phenomenon that both these tracts are lying close to each other, and there is a chance that your motor muscles may start to improve as well. And these are the patients who can benefit from aggressive treatment. Acute pulmonary consideration is important. We know that if the injury is at C1 to 3, your cough function is going to be absent. At C4, it will be completely non-functional. At C5 to T1, again non-functional. We're talking about cough function itself. At thoracic level, it becomes weak because our muscles and the thoracic spine, the diaphragm is weak as well. And if it's D5 to D10, it's poor. We know from D11 below, it's completely normal. So the vital capacity also changes in the acute phase. And we can see here from C1 to 3, it's 0 to 5%. From C4, 10 to 15%. So it keeps on improving as we go down. And from T11 to below, it's normal. And it's important to know where exactly is the level and what are the chances of these patients requiring ventilation afterwards. So let's come to instability. The loss of ability of the spine under physiological load to maintain its pattern of displacement, so there is no initial or additional neurological deficits, no major deformity, or no incapacitating pain. So 3 factors. So no major neurology, no deformity, or no pain. And if you have that, then that's called instability. This is definition going on for now last 26 years. What imaging studies do you need? People do plain X-rays, CT, or MRI. You can do whatever is available, but what the guidelines say, let's look that up first. So we know that plain films could miss half of the fractures. and about 1/5 of the unstable fractures. So it's very, very important that, if we have the capacity to do CT, we get that. And even if you do plain films, we know that we'll be missing things. So we have to look them very, very carefully. And this is a study coming from 2013 from Vanderbilt. Plain X-rays, if you're going to get them, you're going to need to go do AP and lateral. AP, obviously, you need to have spinous process of second cervical down to the first thoracic vertebra. Lateral, from the base of occiput, but you must include C71 junction, because we know that 10% of the injuries happen at this level. So what are the indications of X-rays? All alert patients who have neck pain or tenderness, if the CT is unavailable. Patients with neurology, patients with polytrauma, craniofacial injuries, and unconscious or patients who have got sustained trauma. So what's the Nexus criteria? Nexus criteria is basically to rule out a patient of having a cervical spine injury just on the basis of, did they have a midline cervical tenderness? Are they intoxicated? Did they have any distracting injuries? Do they have any neurology? If they didn't have any of one of these, obviously there is a 90% chance that you're not going to have a cervical spine injury. So that's a clinical criteria that we already have, that we can rule out 90% of these patients not having any injury. Canadian C-spine rule, basically 3 questions. Age more than or equal to 65, a dangerous mechanism of injury, and paresthesias in extremities. And if you don't have any of these, then obviously you say that 95% of the time you will not have a cervical spine injury. Missed injuries could be as high as 1 in 3 patients. So it is really high, 33%. And it can have devastating long-term consequences. It must therefore be presumed until it is excluded. Why CT scan? CT scan, because what we do is we basically do CT of C-spine and head at the same time. Because X-ray may miss fractures, displacements, and CT can give us better visualization of the extent, displacement of the fracture, and also of the posterior discoligamentous complex as well. It has to have a sagittal reconstruction as shown here, and it can show all kind of anterior and posterior injuries if you have a sagittal reconstruction. Why MRI? You can get MRI in some setting if you have availability of MRI in your center, and you can quickly get that and promptly, and your patients are not delayed. So generally speaking, if patients come in trauma, they have a subluxation, and they have a CT, then you there and then put in a tongue, and unless there is a contraindication for it. And MRI basically will help you look at soft tissue, ligaments, discs, intrinsic cord damage, edema, hematoma, myelomalacia or contusions, and looking at the paravertebral soft tissue to see if there's posterior complex involved, if there's blood anterior to the body, inside in the disc space. And obviously, it's excellent in assessment of brachial plexus injury if you're suspecting one. So what happens in an obtunded or unconscious patient? So patients with normal X-ray and fine slice CT have a 98% chance of not having a significant spinal injury, particularly unstable injuries or subluxation. MRI scanning, again, does not give 100% clearance, and but there's a very low chance of a potential unstable injury that could be missed. So there was a recent study that looked at 1,400 patients who went through a CT protocol and looked at fine slice CT with reconstruction, and realized there was only 1 patient who had a significant cervical injury which was missed and required surgery. So the numbers are very, very small for us to be able and it is about a 100% sensitivity and a 99% specificity. If you look at this, I'm not sure if you can see this slide very good, but I can't put it much bigger than this. So these are basic guidelines. You've got awake, asymptomatic patients. You don't need to worry about if your Nexus criteria is clear. If you've got a symptomatic patient, high quality CT is normal, and basically if your X-rays are normal, then and the study is normal, then obviously the attending physician can take off the collar. If you've got an obtunded patient, if your high quality CT is normal, MRI is normal, you involve a spine specialist, and if they're happy or the MD concerning looking after the patient is happy, then you can take the collar off. So can we do an awake closed reduction? There was a study in 1991, and they looked at 55 pre-reduction MRI, and 54% incidence of disc herniation. There was no neurocompromise in awake and alert patients who had a closed reduction. So basically, they're saying it was safe to go ahead and do it. Another study from 99, 46% had disc herniation who had closed reduction, and there was no correlation with the outcome. Vicaro looked at it again, 11 patients, pre-post reduction MRI. There were 2 patients who had herniated disc. 5 out of 9 patients had a post-successful closed reduction. MRI did not have any knowledge of showing any neurological deterioration. So basically, you do not need an MRI beforehand. If there is a delay in getting MRI, you can proceed and do a closed reduction, put in a tongue in ER, and you can do that. So which are the patients that we do need to put in a traction? They can be treated. The fractures include displaced Jefferson fractures, hangman fractures, type 2 and type 3 odontoid pec fractures, displaced subaxial fractures, and subaxial subluxation and dislocations, which are majority of the patients that we see. In the hangman type 2A fracture, traction may displace the fracture and adds dramatically to the risk of spinal cord injury and subsequent death. So that's what we should not do at all. Flexion injuries, these are the different types of injuries that we see. I'm not going to go into detail about that because basically I'm just telling you about particular management protocol for majority of these patients and the guidelines associated with. Some of the flexion distraction injuries, and you can see there's unilateral subluxation here and a bilateral subluxation shown here with rotately atlantoaxial dislocation shown in this patient. So pediatric spinal cord injuries, they are completely different because they're difficult to immobilize, difficult to diagnose just on plain x-rays. CTs are essential, MR is helpful. Manual inline stabilization is used instead of a semi-rigid collar. Collar sizing can be sometimes difficult, and there may be difficult getting a collar for infant who's less than 6 months and below. Cervical spine injury classification obviously comes from different type of classification. This is one of them. Anderson came up with this, and basically he divided them into 4 groups. Anterior involving the anterior elements, which are shown here, right lateral, left lateral, and posterior. Unfortunately, the classification is not reproducible as such, and when we looked at it in different studies, did not find it as helpful as the newer classifications. So the Vicaro came up with this classification in 2005, and then in 2007 he published this with the spine trauma study group, and he called it a subaxial spinal cervical spine injury classification system, and in which he basically had morphology in which he talked about these 4 morphological patterns which are simple and reproducible. So basically saying that there could be compression, there could be burst, or distraction with flexion or extension, and then translation, and then rotation. And he gave them scoring accordingly. So he gave for burst, he gave 1, and for compression he gave 1, for burst he gave 2, for distraction with burst facets with hypertech extension gave 3, and rotation and translation gave 4. So basically gave this scoring system, and then looked at the discoligamentous complex, in which when it was intact, both on CT and MRI, you got 0. When you're not sure, then you gave it 1. When it was clearly disrupted and the facet was burst or dislocated, you gave it 2. Then you added those scores, and then you looked at the neurology. And what he did was, he did the same what he did was with the thoracolumbar classification, that he said if the neurology was intact, you got 0. If there was root injury, you got 1. Complete injury, you got 2. And the incomplete injury got 3 because...
I have a slight audio problems. Hopefully it'll be solved.
Can you hear me? Hello? Can you hear me, guys?
I'm hearing you, sir.
I can hear.
Okay, so shall I carry on?
Yes, we can hear you. Can you hear us?
Yes, I can hear you. I thought I heard some anyway. And
No. We have muted the microphone, but we can hear you.
Okay, great. So neurology, obviously, the complete and incomplete scoring system was different because we wanted patients who had complete injury were not the ones that we wanted to do them first. It was the ones with the incomplete injury. So we gave them incomplete injury a higher scoring compared to a complete injury. And if there was a continuous cord compression, we gave an extra plus. And we added these scorings. And the higher the score you had, the more we said that you should do surgery. So if your scoring system was more than 5, you said, okay, fine, we need to think about surgery. Whereas if it was less than 5, then we said it depends on the MD's discretion, but generally speaking, you may not require surgery. And then we look at the evidence that was there in the guidelines, and we look at level 1 evidence that both these classifications, cervical spine classification of Vaccaro and Anderson, were pretty reliable, and there was internal consistency indicated by worsening of scoring reflecting worse injury. So the higher score that you had, the worse the outcome there was. So for example, if you had a patient like this, a 25-year-old driver, neck pain and tingling in arms with no neurology, so he basically had a burst fracture, so we gave it 2, and then we gave no neurology, obviously got 0, and the posterior ligamentous complex was not involved, so you got 0, so the score was only 2, so this patient did not require surgery. So the cervical spine injury guidelines now clearly say that for radiological assessment for asymptomatic patient, in the awake asymptomatic patient who is without neck pain or tenderness and who has normal neurology, who is without an injury, distracting from an accurate evaluation, and who is able to complete a functional range of movements, examination, radiology evaluation of the cervical spine is not recommended. So basically somebody sitting, talking to you, has no pain, does not require a radiology and does not require cervical collar. So in the awake symptomatic patient, a high quality CT is recommended. If it's not available, at least a routine 3-view cervical spine radiographs are not recommended. If it is available, then it's not recommended. If it's not available, then you can get those x-rays. But as soon as you have CT, you should supplement it with CT. In an obtunded patient, again, same thing. High quality CT is essential. If not there, then plain x-rays followed by CT. What about methylprednisolone? There has been a lot of talk about methylprednisolone over the years. Unfortunately, many surgeons, spinal surgeons all over the globe were sued, ended up paying a lot of money, had a lot of trouble, and just because of these trials by Bracken. So basically, this was treatment options for acute, traumatic, non-penetrating spinal cord injuries include the administration of a high dose of anti-inflammatory agent, methylprednisolone, within 8 hours. They did 3 studies. However, in their 3rd study, methylprednisolone failed to demonstrate an effect in comparison to placebo. Additionally, they showed there was increased risk of infection if this is used. So there is level 1 evidence that it should not be used any longer. And there was this big national acute spinal cord injury studies critical appraisal by Ed Benzel, Coleman, and Greg Trost and group, and they basically said the reporting of results of NASCA studies 2 and 3 have been incomplete, leading clinicians in the spinal cord injury community to use or not to use methylprednisolone in acute spinal cord injury on the basis of faith, rather than a publicly developed scientific consensus. So the guidelines now say is that administration of methylpred for the treatment of acute spinal cord injury is not recommended. It is not approved by FDA. There is no class 1 or class 2 medical evidence. There is class 1, 2, and 3 evidence that high-dose methylpred or steroids are associated with harmful side effects, including death. So if you look at it, in 2002, the recommendation said there is insufficient evidence to support treatment standards. There's insufficient standards to support treatment guidelines. But they said you had the option of using methylpred for either 24 or 48 hours, and but as long as you're aware of the harmful side effects. In 2013, it has changed completely. there is level 1 evidence that administration of methylpred for the treatment of acute spinal cord injury is not recommended. Clinicians considering methylpred therapy should bear in mind that the drug is not FDA approved. There is no class 1 or 2 evidence supporting its clinical benefit. In fact, there is class 1, 2, 3 evidence that you should not use it as it has harmful side effects, including death. So, can you do conservative treatment in these spinal cord injury patients? There was a study in which they looked at retrospective cohort of patients using halo-based immobilization with anterior cervical fusion for the treatment of subaxial cervical compression flexion fractures like teardrop fractures. 4 of 24 patients eventually required surgical treatment. Functional outcome as judged by SF36 was equivalent between the two groups. The retrospective nature of the series and its treatment was determined on the preference of attending.
Thank you very much, Dr. Shariff, for an excellent presentation. And we invite you and the neurosurgical community of Pakistan to join us in future online conferences. Good day.